Hello, I'm Dr. Anand Mamdani from the Department of Neurology. This is the second module in the series of altered mental status. It focuses on states those mimic coma. This module has two objectives. After finishing this module, you should be able to identify other states which mimic coma and differentiate between coma and other mimics. Several different states of impaired cognition or consciousness may appear similar to coma or may be confused with it. Moreover, patients who survive the initial coma may progress to certain of these syndromes after varying length of time. Once sleep-wake cycle becomes established, true coma is no longer present. Differentiation of these states from true coma is important to allow administration of appropriate therapy and to help determine prognosis. Most common coma mimics are locked-in syndrome, abulia, catatonia, pseudocoma, persistent vegetative state or unresponsive wakefulness syndrome, minimally conscious state, and cognitive motor dissociation. We will be discuss all these coma mimics in this module. Patients in locked-in syndrome, which is also known as deferented state, are alert and aware of their environment but are quadriplegic with lower cranial nerve pulses. They can move their eyes vertically or blink voluntarily. By doing that, they would be able to follow commands. Patients with locked-in syndrome have lesions in bilateral ventral pons like pontine stroke due to basilar artery occlusion and central pontine myelinolysis or brainstem mass. It preserves reticular activating system but involves corticospinal, corticopontine, and corticobulbar tracts. The similar state may be seen with severe polyneuropathy like AIDP, myasthenia gravis, and neuromuscular blocking agent administration. Patients with abulia or akinetic mutism have severe apathy in which patients have blunting of feeling, drive, mentation, and behavior. They most likely have silent, alert appearing immobility and they lay immobile and mute. They don't have any spontaneous movement but they are not paralyzed or weak. Wakefulness and sleep-wake cycles are preserved in these patients. Patients with abulia or akinetic mutism have lesions in bilateral frontal medial region involving cingulate gyrus. Patients with catatonia, most likely akinetic, are mute with marked decrease in motor activity, but they are able to maintain body posture with preserved ability to sit or stand. They don't have any structural lesion. It's a psychiatric manifestation which may be mimicked by frontal lobe dysfunction or drug effect. They respond well to benzodiazepine therapy. Pseudocoma, also known as feigned coma, is a condition in which patient appears comatose, like unresponsive, unarousable, or both, but has no structural, metabolic, or toxic disorder. Patient with persistent vegetative state, also known as unresponsive wakefulness syndrome because of negative impact of the word vegetative, will have absent cognitive function but retain vegetative component. They won't be aware of self and environment. They will not be interacting with others. There will be no evidence of sustained reproducible, purposeful, or voluntary behavioral responses to visual, auditory, tactile, or noxious stimuli. There will be no evidence of language comprehension or expression, but intermittent wakefulness manifested by presence of sleep-wake cycle will be preserved. They will have sufficient preserved hypothalamic and brainstem autonomic function to survive if given medical and nursing care. They will have bowel and bladder incontinence and variably preserved cranial nerves and spinal reflexes. Minimally conscious state also divided into plus, minus, and E, which stands for emergence, is diagnosed with evidence of self or environmental awareness on reproducible and sustained basis, like follows simple commands, gestural or verbal yes or no response regardless of accuracy, intelligible verbalization, in purposeful behavior including movements or affective behavior that occur in contingent relationship to relevant environmental stimuli and are not due to reflexive activity. In summary, there are many states which can mimic coma, and it is important to differentiate those from coma. Patient with locked-in syndrome will be alert and aware, can move their eyes vertically and blink voluntarily. Abulia or akinetic mutism patient appears alert. They have wakefulness and sleep-wake cycles preserved. Catatonic patient maintains body posture with preserved ability to sit and stand. They respond well to benzodiazepine therapy. Pseudocoma patient will have no structural, metabolic, or toxic disorder. Persistent vegetative state or unresponsive wakefulness syndrome will have intermittent wakefulness manifested by presence of sleep-wake cycle. They will have sufficiently preserved hypothalamic and brainstem autonomic functions to survive. Minimally conscious state patient will have evidence of self and environmental awareness on reproducible or sustained basis. Additionally, I would recommend to go through these resources: Neurology in Clinical Practice, Chapter 5, Stupor and Coma, available as ebook at Roland Medical Library, as well as Disorder of Consciousness, Clinical Practice on Osmosis.